now recording, so let me. All right. It is in the book. All right, here we go. So this is diabetic emergencies and altered mental status. So this is going to cover a lot of stuff, okay? Added some stuff that's not in your textbook, so you'll recognize that stuff, hopefully. But like I said, we're going to kind of work through this a little bit slower just because I don't want you to miss this. This is kind of the first chapter that lumps a lot of problems that sometimes are not related. Respiratory was like all respiratory, and this truly is all brain stuff, but it kind of hops around a little bit, okay? So if I'm start moving too fast or I blow over something that I shouldn't have or whatever, just remind me, slow down, so on, okay? All right, so looking at the brain itself, right? The brain is a pretty unique organ in the fact that it falls in a system, but it also controls other systems, right? It's not in your respiratory system, but it controls your respiratory rate. Does that make sense? So it's kind of a weird organ, okay? It's pretty impressive. So what we're talking about is the RAS system, okay? So the reticular activating system. This is what's responsible for functions like staying awake, paying attention, when to sleep, when not to sleep. Hopefully that's what's working as we speak, right? That's what's in charge of keeping you alert and oriented, okay? So when we ask questions like person, place, time, and event, what we're looking at is this person, RAS system, acting like it's supposed to? Make sense? So the three things that your brain has to have, or your RAS system has to have to function, it's got to have oxygen, it's got to have glucose, it's got to have water, okay? Anytime your patient is suffering from altered mental status, those three things need to be on your differential diagnosis list, right? Is it hypoxia, which is the #1 cause of altered mental status, okay? Is my patient hypoglycemic, okay? And then, is my patient dehydrated? Make sense? So those three things, got to have oxygen, got to have glucose, got to have water. Okay? Without one of those, then your brain suffers damage. Okay? And don't forget, what organ dies the fastest in your body from lack of oxygen? Your brain. So replacing these or fixing these in a timely manner, like really, really fast, is important when it comes to, is it going to be a permanent deficit or a temporary deficit? Make sense? The term we use a lot with the heart and the brain is time is tissue, right? The longer time it's not getting oxygen, the more tissue that is damaged. Same, your heart's the same, your brain's the same, right? Time is tissue. Okay? So causes of altered mental status, you can write these down. We're gonna hit a couple of these in depth, but deficiencies in oxygen, glucose, or water, right? Deficiencies in hypoxia, hypoglycemia, or dehydration. Then comes trauma and infection, okay? Then, of course, there's the toxins and alcohol, and we'll talk about strokes. We're going to talk about TIAs here in a little bit. Or it could be something from a different system. Your respiratory system is failing, therefore it's causing damage to your neurological system, right? That's one of those things I was telling you about that we're finding out that a lot of EMT classes are not teaching. How do you take care of patients with more than one problem, right? So in this case, let's say you've got a patient who is altered, and you believe this is a respiratory problem. Are you going to treat the respiratory problem to fix the brain problem? Yes, right? Give them oxygen or positive pressure ventilation, which you would hope would then cause an improvement in that neurological system. You would still assess for other things, right? Don't get in the bad habit of once you find one thing wrong with somebody that you just stop there, right? When we get into shock, we'll talk about, you're doing a patient assessment. Let's say you get to the chest and the person's shot in the chest. Most of us want to stop, right? Now, it's a life threat, so stop and fix it, but then we forget, could they be shot somewhere else that could still cause more shock-like symptoms? Absolutely, right? So once you find one cause of something, don't stop. Go clear to the end of your list, and then make sure you've covered all of your bases, okay? All right, That's the only pathophysiology you get. Okay, what makes altered mental status patients dangerous to us? Why are they dangerous? So they could be angry. Sometimes they like to fight. Okay, and I'll tell you, there's two sides of this, and I'll be totally honest with you. I think I said this to somebody the other day. When I very first started in EMS, I used to think I wanted to fight people in the back of an ambulance, right? It was like I would love to get in a decent knock. I played hockey for 12 years, right? Fighting's fun. I'm not very good at it, but it's fun, right? I will tell you the last place you want to get in a fight is the back of your ambulance, right? It's miserable. There's no room. They have weapons. You look for weapons, right? They seem to find them faster than you do, right? It's just a miserable place to fight, especially because your balance has to do with your driver, right? They slam on the brakes, you all go toppling to the ground. You hope they end up on the bottom and you end up on top, because if not, they get on top of you and start pummeling your face, right? Now, there's two types of people, in my opinion, that are violent. There's the people who intend to be violent, and there's the people who are unintentionally violent. Your diabetics, your hypoglycemics, your head injuries, your stroke patients, your tumor patients do not intend to hurt you. They may be violent and kicking the crap out of you, but if there's something wrong with their brains, they don't know what they're doing, right? This is the 90-year-old lady who's having a stroke who picks up a kitchen knife and comes at you, right? A little different than the guy who injected heroin or methamphetamine who wants to kick the living tar out of you, right? In my opinion, I'm more likely to drop him than I am the 90-year-old lady with the butcher knife, right? Because, for one, it's wrong. Well, the second side of that is that person doesn't know what they're doing. Neither does the meth head, I understand that, but they are intentionally trying to injure you, right? So you've got to look at both sides of that. Your combative patient may not be intentionally combative towards you. Use law enforcement when you can, right? I know Jay talked, not calling them on the 90-year-old lady with a kitchen knife. I would probably call law enforcement for a 90-year-old with a kitchen knife, right? Can they still stab and kill you? Absolutely. Can you trip them and they'll fall and you can take the knife away? Probably. Just don't break anything on the way down. Okay? Yeah. So, the word syncope, right? Written right down here. S-Y-N-C-O-P-E. Okay? What does that word mean? Fainting. Right? I don't know why EMS loves that word. We use it all the time. Right? Syncopal episode, syncope, it's passing out. Right? It's fainting. Okay? So kind of keep that in mind. Any dangers in this area, or in this picture? She could have hit her head, so you can go on the medical side of things, right? Remember way back in our patient assessment, at which position would you approach her, from which way? Say again? You're hosed on this side, right? So if you came around this corner, you would pretty much have to approach her from the head, right? Now, there's a perk here, right? You do have the ability to see both hands, right? So that's good. She could still have weapons, right? Could be tucked inside a waistband, something along those lines. There also could be weapons somewhere over here that you can't see, right? So just maintain your scene. If this is a warehouse or something, make sure this isn't, there's nothing stacked up on top of this. Then you start asking questions like, why is she on the ground, right? Did someone see her fall or did they not? If this person's unconscious and no one saw her fall, would you hold C-spine? Yes. Now, if she's conscious or someone saw her go to the ground, what are the questions that you're going to ask to rule out the need to hold C-spine? Did she fall? What else? How do you mean, Jordan? Okay. Okay. Was it a standing fall or was it a fall from height? What else? Okay. I like that. What else? Okay, so yeah, ask her questions, right? Did you hit your head? One of probably the dumbest questions we ask people that we still ask is, did you lose consciousness, right? If they lost consciousness, they don't know they lost consciousness, right? So you can say, do you have memory that you feel like is missing, right? Do you remember laying on the ground? If they say something like, I was walking and all of a sudden I woke up and you're standing here, guess what? They lost consciousness. Then comes, do you have any head, neck, or back pain? You're going to have to palpate. Okay? As long as there's nothing that raises a red flag, then don't worry about C-spine. Okay? Head, neck, or back pain, or a fall from a height, or unwitnessed fall, or an unconscious patient, and we can start being concerned about holding some C-spine. So we talked about this already, right? But hypoxia is the most common cause of altered mental status, which means if your patient is altered, then number one on your list needs to be hypoxia. Make sense? Number one on differential diagnosis. We tend to put things like hypoglycemia and stuff. That's awesome. Put hypoxia number one. Okay? The best way to fix hypoxia is to make sure they have an airway and make sure they're breathing adequately. Then worry about supplemental oxygen. Right? Right now in Spokane County, if your saturations are between 94 and 96% and you're having a stroke, we do not give you any oxygen. Okay? Remember, this is a vasoconstrictor, which means if you give oxygen, 15 liters on a breather, to a stroke patient, you increase the brain damage they're going to have. Right? The oxygen itself is causing the damage to the brain. Okay? So between 94 and 96% or higher, forget the oxygen. Okay? They don't need it. Okay? There's a direct relation there. If it's inadequate, their saturations will be low. Does that make sense? You're not going to have someone with the saturations of 96% who's breathing 2 times a minute. Right? So you're not going to have to make that decision. Well, they're inadequate, but their stats are good. Inadequate breathing and low O2 sats go hand in hand. If you have someone who's cyanotic and altered and a poor rate and you have an SpO2 that's normal, you should be thinking your SpO2 is giving you a false reading. Right? Treat your patient, not your equipment. Okay? So, still priority is identify and treat life-threatening problems. That really hasn't changed. Consider oxygen administrations as long as it applies when it's needed. Suction. Is vomiting common with altered mental status? Yes. Are altered patients able to control their own airway? Not normally. Right? So, either recovery position, or if they're conscious and alert, get them up off their back and get them in a sitting position. Okay? How do we get baseline mental status? What are the questions you ask them? Person, place, time, who the president is. Be careful with the words. Right? What's your name? Where are you at? How old are you? What year is it? What day is it? Whatever. Who's the president? Right? They answer all those questions appropriately? Awesome. If they miss one or two and you're dealing with a geriatric patient, find out if this is normal. Right? A dementia patient who says it's 1948, that may be what they always say. Right? That may not be an indication this is new. It might be an indication of they're always confused on what year it is or what day it is or whatever. I hate the what day is it question. Right? I don't know the answer half the time. Right? I look at my partner. Is he good? And they're like, yeah, awesome. Right? Ask a year. That usually is okay. If it's January 1st, they give you the wrong year by last year, give them a break. Yeah. Yeah. You know what? I don't remember. I think it's February, but it's supposed to be March. Right? People are super fun when they ask these questions. I love it. So, thoroughly examine patient exhibiting new unusual behavior, right? Any new onset's a problem. Okay? All patients with altered mental status, here are the 4 things I'm going to expect of you from this point on. Okay? You need to take a glucose. You need to get an SpO2. You need to you need to do a FAST exam. We're going to talk some additions to FAST, and you need to check pupils. Okay? How many of you have already written reports for your shift besides Blair? Anybody else? On paper, that's fine. So, Blair's the only one who gets off with this. Okay? From now on, your charted exam, if you have a neurological patient, this is what you need to document. What's their glucose? What's their SpO2? Was the FAST exam positive or negative? What are their pupil sizes, right? That goes in your assessment piece, right? All your reports should get better and better as this class moves on. Make sense? Because cardiovascular, I gave you a whole exam you can do that you should be adding into your report. Respiratory, we talked about all the things you would account for. Now we're talking about, you see what I'm saying? As we move through this class, your report should get more and more accurate. Now, let's say you have a boring call, right? It's going to happen, okay? I'm not grading your reports on how entertaining or how much you did on your patient contact, right? Your boring calls, right, these guys that work in the fire department, boring calls, do you still have to write reports? Yes. Can those reports still get called into court? If you half-ass your boring calls, are you still going to get sued? Yes. So write your reports the same no matter what, right? Nothing on that grading sheet that I'm talking about is about how much you have in there. If you did nothing as an assessment and you document head, not assessed, eyes, not assessed, ears, not assessed, and that's how your assessment goes, you still get full points, right? If you have no vitals, I'm going to dock your points, right? Frankie had an interesting experience, and we'll use her example to educate all of you, right? You're going to ride with agencies who may or may not have interfacility transports, right? Hospital to hospital, okay? Those are the boring calls, okay? Most of us have the bad habit of sitting there and doing absolutely nothing, right? Frankie will tell you her paramedic didn't take vitals during the interfacility, right? That's fine. Is that not a really good time for you to be like, hey, do you mind if I take vitals? Do you mind if I ask some questions? Does that make sense? You're there to be a student, so be like, hey, if this was a more critical call, ask them questions. Or when they're all done, what are the questions you would have asked if this would have been in a facility or whatever? You still have to document, right? If you're watching the entire, if the paramedic says sit on your hands, you're better seen than heard, just sit there. Can you still write a report? Absolutely, right? Because they're going to be asking questions, so write that stuff down. Does that make sense? You can still write good reports if you're just watching, okay? Talk to those paramedics and the advanced EMTs and EMTs you're working with and be like, hey, you know, can I take a set of vital signs? I know you don't plan on doing it, but I'd like to use the practice, right? The more you know what's normal, the better you're going to recognize the abnormals, okay? Go ahead.
So we had a hospital trip, and
Mm-hmm.
the paramedic, I don't know if it's part of the practice of the people who were put together. He tracks like eye movement.
We're going to talk about that.
And CMS, or like brushing.
Mm-hmm. We've added that. It's not FAST exam, right? There's the FAST exam, there's the Cincinnati stroke scale, there's the Los Angeles stroke scale, there's a MACE stroke scale, there's a rate, there's all these different stroke scales. We're taking those pieces that we're going to teach you today, in addition to FAST, you're going to do these few things. It's part of, we're combining part of the Miami, I think it's called Miami Emergency Physicians Assessment Stroke Scale, and the RACE stroke scale with FAST to give you those extra tools. Because we're finding out that our stroke exams need to be a little bit more in-depth, okay? All right, so performing your primary assessment, where is mental status in your primary assessment? Like number 1 or 2, right? It's general impression, mental status, chief complaint, A, B's, and C's, right? So you could argue this mental status is a priority above airway, breathing, and circulation, okay? Body system exams and complete history may reveal information about the suspected cause of the altered mental status. The only way you're going to pick up on it is if you do a body system exam. You might assess the respiratory system and find out this is a neurological problem. You might assess the endocrine system and find out this is a neurological problem, okay?
Did you put mental status number 1? Because what you notice that, and then if you form a general impression,
Mm-hmm.
I mean, would that be a good idea?
You can. The order in that primary assessment is not critical. Like it doesn't. You don't have to go general impression, level of consciousness, chief complaint, A, B's, and C's. You could do A, B, C, chief. You know, it doesn't really matter. But you can throw level of consciousness in with your general impression, unless they're unconscious. Then you can't, because in order to get an accurate level of consciousness, you have to initiate painful response and so on. Right? General impression is hands off. General impression is what do you see. And so if they're conscious and alert, you can justify level of consciousness and general impression. But most places we keep them just separate by just a little bit of Interview family, right? If you get any information from the patient, interview family. Remember last week's scenarios, Vince's team had the cardiac arrest, right? Interview the bystanders. Now, in that circumstance, they'd have given you no information whatsoever, but still ask the questions. What were you doing? What happened? Did they say anything before they collapsed? Do you know if they have any medical history? Do you know if they have any allergies? Do you know if they take any medications for anything? What's their social security number? What's their birth date? What's their first name? What's their last name? All that crap's going to get asked of you when you get to the hospital, right? Now, there's a really short window, because if your patient's critical, you don't want to spend a lot of time on scene, right? So send someone to get that information, because once you leave the scene, you just left your one source of information if your patient is unconscious, right? So you get a team of 4 people, sacrifice one person and go, hey, go talk to family, get as much information as you possibly can. I want to be gone in 10 minutes. 10 minutes is up, they give you a sheet of paper that has all these questions, right? Sample, OPQRST, any additional information, all that stuff is pretty important, okay? Even if your patient is conscious, family might be able to give you a little more information than the patient can. Utilize family as a resource as long as family is not part of the problem, okay? Unconscious people or altered people, always think of part of your general impression and part of your patient assessment, look for medic alert bracelets. Okay? Things like diabetes, things like cardiac, things like allergies, that stuff's important. Go ahead, sir.
I didn't think about this, but the people that have medic bracelets and say DNR, do not necessitate.
Doesn't count.
I didn't think so.
Yeah. It might key you into, hey, go take a quick second, look around, see if we can find one. Is it on the fridge? Is it on the door? Is it on the coffee table? Something like that. But it doesn't count as a true do not resuscitate. There's a great article about should tattoos count, right? Me tattooing do not resuscitate across my chest. Should that count? Not unless the doctor is a tattoo artist who can sign his name on your chest, right? Doesn't count. Not yet. Probably see that coming, right? Where tattoos, bracelets, stuff like that will count as DNRs. Good question.
Do you get in trouble if you can't find them all? Like if you look on the fridge and the table and all that?
Well, a person's going to get real, real angry is if you save their life and they didn't want you to. And they can be like, that was rude, right? You just put it somewhere where it's easier to find, right? We had a frequent flyer that every time she found her own DNR, she'd tear it up, right? Because she was a little different, right? She would forget, so she'd find it, she'd tear it up, she'd throw it in the trash can. So family came to us and said, look, here's the deal. We taped it to the back of a cereal box that they put on the back of the fridge where she couldn't reach it, right? Signed by her, legal binding document, but she would have these weird periods of lucid or not lucid where if she would find it during that period, she used to hide her medications because she thought someone was stealing them. So we'd show up and be like, well, where's your nitro? And she would say, I don't know. We go looking through her house and find it in a drawer, in a room, or under something under lock and key. I mean, so there's lots and lots of problems. And so the nice thing is you might have extenuating circumstance where family comes to you and says, hey, this is where it is in case this does arise.
Can people put them on file with a local agency? Like
Not that I know of.
to the fire department and we're like, hey.
Not that I know of. I don't know if that's a HIPAA thing. I don't know if it just isn't done. There might be agencies nationwide that do it. Not that I know of. No, how's this? It doesn't happen here.
Okay.
Make sense? They could sure probably try. Right? It's just like anything else. Yeah, sue me, I dare you. I'll sit in court all day long and really apologize for saving your life. Over and over and over again. Yeah. The doctor tells them on a fridge, on a door. Nursing facilities usually have like a folder or something that's secure on the outside of the door. That's you walk in the door of the patient and all the information's right there. We recommend like on a fridge or on their door or next to their bedstand or something that we can physically see. The reason why it's that ugly green color is it's like like it picks up your vision really, really quick. Yeah, we try to educate them, but they got to follow directions. Pediatric Note, right? They obviously can't answer as many questions as adults, and depending on that age group, they ask less and less questions, right? but ask parents and caregivers, are they acting any differently than normal, right? Is this out of the ordinary? Is this typical? Ask questions about, how much have they been sleeping? How much have they been eating? How many wet diapers, if they're in that age group, have you been changing? Because we're talking about dehydration. Still the same things affect kids that affect adults, right? Kids burn oxygen twice as fast as adults. So they burn through their reserves much, much faster than what adults do. Okay? So let's talk about diabetes specifically. Okay? That was the broad stuff. Here's the specific stuff. I really know that was going to be you who said that. All right, so glucose is a form of sugar, right? It's our basic source of energy. ATP has got to have sugar. Okay? Now, you've got to utilize glucose properly to stay alive and create energy. Okay? Now, the problem with glucose is the glucose molecule itself is too large to get into the cells. Okay? It floats around in the bloodstream, but without insulin, it can't get into the cells. Okay? Done? Good? Okay? So without that insulin, it doesn't leave the bloodstream. And if glucose just sits in your bloodstream, what are your glucose levels, high or low? High, right? Because it just circulates in your blood. Now, if glucose just keeps getting dumped into your bloodstream and your sugar gets higher and higher, can your blood become so acidic it turns into sepsis that can kill you? Yes, right? Now, if you have too much transition, so either A, you don't intake enough sugar, or B, all of your sugar leaves your bloodstream and goes into your cells, can that cause problems? Yes. Okay, so there's the both sides of that. This is just a visual, right? What organ is in charge of producing that insulin? Your pancreas. When we talk about endocrine emergencies, we're almost always talking about diabetes. What is the other form, or what is the other issue that can happen with your pancreas that is a problem? Pancreatitis. Okay? What's the leading cause of pancreatitis in adults? What do you think? So that's like number 2 or number 3. You're almost spot on. What do you think? Alcoholism. Right? Number 1. Okay? With alcoholism, it damages your pancreas, it damages your liver. Right? Number 1 cause of pancreatitis is alcoholism. Okay? The biggest contributing factor to pancreatitis is smoking. Right? So you get a alcoholic or recovering alcoholic or whatever, pancreatitis is really, really common. Right? What do those patients usually present with? What's the big red flag? How do you know it's pancreatitis? So true, but toe pain, arm pain, what kind of pain? Where? There's 4 quadrants. You got to be specific, right? Upper left usually. Right? Now, does your pancreas sit in both right and left quadrants? Yes. Right? But usually it presents with high right abdominal pain. Right? And people say this is, I've transported plenty of these, say this is absolute miserable pain. Like 11 out of 10. Right? Burning, stabbing, tearing, shearing, all of them. Right? Basically high up in your stomach. Okay? So, insulin in the pancreas. Your insulin is produced by the pancreas, right? The purpose is it allows, we call this the lock and key, right? The key to get into the cells is insulin. Okay? There's how many types of diabetes? God bless you. 3? You sure? 2 or 3? Is there type 1? Yes. Is there type 2? Is there gestational? I hate when that happens. Right? So type 1 diabetics, what's the problem? So that's the solution, but what's the problem? Their pancreas doesn't produce insulin. So they turn into insulin-dependent diabetics, right? They have to take insulin on a regular basis. Now your type 2 diabetics, let's speed up, we'll come back to this. Your type 2 diabetics, it just doesn't utilize the insulin like it's supposed to. okay? That's usually controlled by oral antidiabetic medications or diet, like a real strict diet, okay? You end up at, like INHS, we have a whole division or department that is diabetes education, right? We bring people in who are pre-diabetic or diabetic. We talk about meal plans. They test their A1Cs and find out what their sugar level has been on average for the last 3 months. And they look at, when does your body produce insulin? When should you be eating? How much should you be eating? They control how many carbs, how many grams of sugar. All that diabetes education goes into matching a diet plan that fits your body. Make sense? I'm going to go back to this just for a second. So really, when you're looking at this, your pancreas is that key piece, okay? My last EMT class, we had a kid that was a rock star college football kid from Eastern, right? Came from Idaho, hugely sought after, was going to go to the NFL, whole 9 yards, right? Takes a helmet collision to his gut that damages his pancreas that gives him diabetes, right? Unique case in the fact that at the age of, I think he was 19, he then had type 1 diabetes, which is pretty uncommon because normally type 1 diabetics you get when you're a kid, right? So in this case, 19 years old has to change everything, right? Because you think about a bodybuilder or an athlete, how much food they're used to. He's working out 3 and 4 times a day. He's used to ingesting so many calories that it was messing with his diabetes, right? Had to quit football, lost all of his scholarships, everything, right? So now he came and be an EMT. That was his life choice. Couldn't think of anything better. All the smartness in your brains, that was it. Okay, what's gestational diabetes? What? Yeah, you get diabetes when you're pregnant, right? So you get it when you're pregnant. Normally it goes away when you're not pregnant, right? But think about what happens, the damage that's done to you when you have diabetes, right? Poor diet and whatever. Now, and you will hear me, I don't mean this in a bad way, right? I have a daughter, but babies are parasites, right? For 9 months, probably closer to 18 years, but for 9 months, they truly are parasites, right? In mom's body does not give them oxygen, sugar, and blood, right? The baby takes it from mom's bloodstream, right? Mom's body doesn't give it to him willingly. It takes it. Mom's body compensates and gets more blood volume and intakes more oxygen and so on. But if mom dies, baby doesn't stop taking away her reserves. Baby just takes and takes and takes and takes until it's not there, right? Which I've been told doesn't end until they're at least 23, 24. Probably more. Mark's like, I still call my mom and dad for money. Okay? So, which is the more dangerous and life-threatening one you're going to encounter? Hypoglycemia or hyper? Hypo, right? Hypo kills you in minutes. Hyper kills you in days or weeks. Okay? And by minutes, we're talking 30, 40, 45, right? Not like 1 minute you're dead, but it kills you much faster. Okay? Your hypoglycemic patients, the causes that is the hypoglycemic side is either A, they take too much insulin, B, they don't eat, C, they overexercise or overexert themselves. The next one is they vomit, so they get the flu, right? And the next one is that something increases their metabolic rate, like fever or shivering, okay? Which kind of falls in with this other one. Most commonly what we see is patients who accidentally take too much insulin and then forget to eat, right? Most of the diabetics you will go on are usually in the very, very early hours of the morning, right? They take their insulin before they go to bed, and they eat a lighter than normal dinner, and they go, hopefully that has a lid. Good thing. I sure hate vodka all over the floor. Then these patients start having breathing problems. Their spouse hears their breathing change, tries to wake them up. They can't wake them up. We show up. We try to fix the problem. Okay? So here's what points to hypoglycemic. right? Because you're going to put hyper and hypo side by side here in a second. So hypoglycemic, it's a rapid onset, okay? It presents with altered mental status, pale, sweaty skin, tachycardia, rapid breathing, seizures. I want to look at something here real quick. Okay, good. So rapid onset, altered mental status, pale, sweaty skin, tachycardia, rapid breathing, and seizures. Okay? The seizures is because your brain's not getting enough sugar. It tries to reset itself. We're going to talk about what seizures are here in just a second. Okay? This comes on fast. They're altered. They present like shock, pale, sweaty, and tachycardia. Right? They're in shock because their brain, their body's not getting sugar. Okay? Rapid breathing. The reason why we're pointing this out so much is this can mimic alcohol, this can mimic drugs, this can mimic stroke, this can mimic all kinds of stuff. Right? Notice when a minute ago I said all altered mental status patients, you check a glucose. Right? Because you can have the stroke patient who's actually a diabetic emergency. You can have the DUI traffic stop that's driving down the wrong side of the highway that law enforcement pulls over, that leads them on a high-speed chase, that they have to pit maneuver, pull them out of the car, and they look DUI, and they're a diabetic. Right? We're seeing more and more law enforcement requesting us to come out and check glucoses, right, on their DUI stuff because they're using that as a CYA. Right? They do not want the guy in the drunk tank who dies because it wasn't a drunk, they were a diabetic. Now, the downfall is as we talk about those things, right, our DUI people start to learn that you use the word diabetic and law enforcement calls 911, right? So you'll get the DUI guy who's like, I'm a diabetic, I haven't been drinking, I swear. You check their glucose and look at the officer and go, it's normal, right? They use this stuff to try to get out of things, okay? Not very uncommon at all. Yeah. Allergy to silver bracelets. Happens all the time. Okay? Results, obviously, altered mental status, unconsciousness, and permanent brain damage. You let this go long periods of time, their brain gets damaged. Right? It's pretty rare that you hear of a hypoglycemic patient who is, how do I put this? It's pretty rare that they have damage done to the brain that's long term. This normally kills them. Right? I have yet to be on a patient who has a traumatic brain injury from a hypoglycemic event, right? Because it's not a traumatic brain injury like a concussion or a stroke or something like that that causes permanent neurological deficits, lack of speech, lack of movement, lack of coordination, or whatever. That's one spot. This affects your entire brain all at the same time. So this is not just going to impair one piece. So it's not going to be, oh, my left arm's numb. It's not just going to be, see what I'm saying? The brain damage that's caused by this is usually irreversible death. Okay? All cardiac arrests, check a glucose. Even if they're dead, right? You're doing chest compressions, check a glucose. Okay? Because when we get on scene as advanced EMTs or paramedics, we can give sugar without them being awake. And it just might be that we give sugar that allows their heart to go into VFib so that we can shock it so that we can save their life. Right? Check a glucose on cardiac arrest. Okay? It's one of your 5 H's and T's, right? One of your 5 H's is hypoglycemia. So here's the hyper side. So this is the high side. Okay? This may be due to your body's inability to produce insulin. So you're ingesting the sugar, but the sugar's not leaving your bloodstream into the cells. Okay? Maybe the patient's not taking insulin like they're supposed to, and they're just eating. Make sense? Those are the causes. Those are the times you usually see it. We don't see hyperglycemic patients very often. Okay? By far, almost all our diabetic patients we see are on the hypo side. It's pretty rare. I've only seen a couple of hyperglycemic patients in my 10-year career. Just a couple, maybe 1 or 2. We're going to talk about that here in a second. it sucks because the textbook's going to give you a number and say anything above this is considered a hyperglycemic. I think that the top end is like 180. It might even be closer to 140, 160. We have patients in Deer Park, their normal glucose is 320, 360, and they're like that all the time, right? So the textbook just gives you a parameter. That's the downfall. It's a one-size-fit-all, but of course we know doesn't apply to EMS. So here's the cause. Stress, okay? Increased dietary intake, that's usually when you see it, okay? Patients who no longer want to be diabetic, right? They're literally just like, I quit, I don't want to be diabetic anymore. So they quit taking insulin, and they just eat and eat and eat and eat and eat and eat and eat, and their sugars just rise, right? We call that failure to thrive, right? Patients who are like, I'm done with this. And I feel bad for a lot of these people. Some of these people have been diabetic for 67 years, right? And they're like, I'm done. I'm done sticking myself in the stomach with needles 8 times a day. I quit, right? And so they just do whatever they want. Well, their sugar either plummets or their sugar skyrockets, right? Diabetes, there's no cure yet. You either take insulin every day and fix the problem, or you pay attention to your diet and follow those diabetes educators, and you live longer, happier lives. Okay? Yes, secretly happy. Signs, okay, this develops over days or weeks. Okay? Why are they chronically thirsty and hungry? Why do you think? Okay, so that there's that side. What else? Why are they thirsty all the time? So it's acidic, which means your body's peeing it all out, right? Your renal system will jump into high drive and start making you pee a bunch, which means now you have that fluid shift and you're losing fluid from where it needs to be, and your body picks up on that, right? That's that increased urination. Okay? Whoops. So the term I want you to write down is DKA, and I want you to write next to it diabetic ketoacidosis. Okay? Great news. I'll let you say DKA. Okay? So diabetic ketoacidosis, this is the very, very high end. Okay? This is, your blood is so acidic, it's actually producing ketones that can lead to sepsis, and this can kill you. Okay? This is the high end of hyperglycemia. This is what kills you. Make sense? So you're not getting sugar out of your bloodstream and your cells, and your sugar levels rise and rise and rise and rise and rise. Then you start getting a couple of unique signs that we can pick up on. Okay? Is it on here? It is. Perfect. So they become profoundly altered. Now this sucks because it makes you want to think hypoglycemia, right? Except for the question you ask is, how long has this been going on? Right? Rapid onset is hypo, longer onset is hyper. Okay? They start presenting like a shock patient. Okay? They're losing blood volume. Make sense? Next to rapid breathing, I want you to write this really fun word, and it's Kussmaul's. 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 Kussmaul's respirations. Okay? That's the rapid breathing. So Kussmaul's is unique. It is fast and it is deep. Okay? So if you think about that, normally if you have fast respirations, what is your tidal volume? Shallow. Right? So why in this case, why is their body breathing fast and deep? It's trying to blow off CO2, which is directly related to your pH, which is being affected by all these ketones and acids being dumped into your bloodstream. Okay? So they breathe real, and most of us can't even reproduce this. Right? Think about a real deep tidal volume, but breathing 38 times a minute. Right? It's almost impossible. Your brain does this because it has to. It's not something you can almost reproduce. Okay? Now, on their breath, they have this either really, really fruity smell or they have this really acetone smell, right? How many of you remember the zebra gum, right? The gum that was like rainbow-colored zebra, different flavors. If you threw that in paint thinner, that's what this smells like, right? Fruity acid, right? They are literally breathing out pure glucose, right, with these acids that are attached to them. And a lot of times, without even breathing, if it's bad enough, it seeps through their skin, right? Your body is dumping its acid as fast as it can. Okay, they pee it out, comes out of their pores, it comes out of their respiratory system. These patients are in big, big trouble. Okay, so scene safety, we've already talked about it. Primary assessment, identify altered mental status as soon as you can. Your secondary assessment, this is in addition to your sample and OPQRST. Okay, how did this occur? When did this happen? How long has this been happening? Are there associated symptoms with your fast breathing? Do you also have tachycardia? With your high glucose levels, do you also have fast breathing? Does that make sense? So associated symptoms with that. Is there anything that points towards trauma? Because trauma to the brain can produce stroke-like symptoms, can produce seizures, can cause issues. Okay? With this, you want to know, have they had a seizure? Why do we care about fever? We'll talk about adults just for now. Yeah, what about the infection side, right? It takes a while for a fever to appear with an infection. So you know we're talking days into this, right? Hours into days. Make sense? This is easy stuff, just the brain. Oops. So determine history of diabetes. Ask the patient. Okay? This is one of the issues that will present on a medical identification bracelet. Okay? Then start looking around to see if there's indicators that there's diabetics in the house. Okay? Look in the fridge because a lot of insulin is stored there. Okay? Look around for syringes on the ground that are capped or syringes that are in a coffee can or a sharps container. Diabetics don't like open sharps. Heroin users could care less. Right? You walk in a house with syringes all over the floor, probably heroin. Right? You walk in a house with a coffee can overflowing with syringes, probably a diabetic. Make sense? Perform your glucose. That's pretty easy, right? Pretty straightforward. We're going to talk about how to take a glucose, and then we'll take a break. Okay? So glucose measures the amount of glucose in the bloodstream itself. Okay? A lot of your diabetic patients will have their own glucometers. I'm a big fan of always using our equipment, right? Because you never know if that patient has to pay for those strips and those lancets out of pocket, right? That's my opinion. Use my stuff, right? Whether you're tax-based organization or non-tax-based, let's use our stuff. That way we're not wasting their stuff. Okay? Make sense? So you find out they're diabetic. You check their glucose, and it's low. Okay? As long as they are, we'll say that for a second, less than 60, and they're symptomatic, you can call them hypoglycemic. What would be a symptomatic diabetic? What do you think? Altered mental status, pale, sweaty skin. Okay? Less than 50 usually presents with some pretty severe alterations in mental status. Okay? I've seen people between 50 and 60 who are totally fine. Less than 50 usually start to see some pretty substantial changes. So here's what I was talking with Blair. Greater than 140 is hyperglycemic. Yeah. Greater than 300 for a prolonged time causes some big issues, right? Those patients that I'm telling you that we see on a regular basis, their sugars are 300, 400 all the time, those are the ones you see with neuropathy and amputations and overweight and so on, right? They're the ones that don't care, don't listen, don't pay attention to what the doctors are saying, and they have the life-altering problems that comes with diabetes, right? Can you live a long, happy life with diabetes and never have to have your legs amputated? If you control it like you're supposed to, you can, right? There are lots, and we're working on like diabetes education in kids, and working on bringing professional athletes in to meet with them to be like, look, it doesn't have to ruin your life, right? It blew our minds like 10 years ago when kids were thinking that because they have diabetes as a kid, their life was over. They couldn't do fun things, right? They couldn't play sports. They couldn't have jobs or, like the unique jobs. You couldn't be a police officer. You couldn't be a firefighter. You couldn't be a paramedic. We're like, no. None of that's true. You just have to listen, pay attention, and control it, and take control of your actions so it doesn't get that bad, right? People that hang out at 300 and 400 aren't those kinds of people, right? They're the ones that you see in wheelchairs and amputations, and they always have issues when it comes to circulation and sugar issues. Most glucometers, anything over 500, it's just going to read high, okay? Also with that, most of them will flash the word ketone, which is your other big red flag that you should be thinking of DKA, anything over 500, right? I think even our monitors, anything over about 390, it starts blinking ketones, okay? Low, anything less than 15 will not give you a number. It's just going to give you the word low, okay? If it shows low and your patient is conscious and awake, your glucometer is broken, okay? I've seen some low patients, conscious and alert and talking, not less than 15, right? That's like, we're talking about brain damage at that point, okay? What do you think the chances are of you giving oral glucose to these patients? 0, because they're usually unconscious, right? Your host, okay? One of the drugs that we're really, really working on giving to EMTs, because now that you can give IM injections of epi, we have this idea of giving you what's called glucagon. Glucagon is a powder that we put into saline. You give 1 milligram IM, and it actually goes to your liver and has it produce glucagon to get glucose out of your bloodstream and into your cells, right? We're working on in Washington State getting that as an EMT drug, okay? Because it's an awesome drug. It's easy. You can't screw it up. It doesn't harm people as long as you're not giving it to, patients who have real high glucoses or something along those lines. We're fine. Make sense? Now, here's the kicker. Everyone always asks this. You're like the first group in 10 years of me being in this that hasn't asked this. There is no one in pre-hospital, not paramedics, not advanced EMTs, not EMTs that can give insulin. We can't give it, right? So we have patients all the time who we present with glucoses of 500, and the simple solution, if you give them insulin, will it lower their glucose? Yeah, we can't give it, right? Now, if there's a family member who's been trained by their doctor to give it, maybe you can, drop that little subtle hint, right? We can't give it. Paramedics can't give it. Advanced EMTs can't give it. Nurses can, but we can't.
Why?
I don't know, right? We've asked that before, and our medical director goes, because. And most nationwide, paramedics can't give it. So I don't know what the dangers, I don't know what the reason behind that is. MedStar, Life Flight Network, critical care people can give it, but paramedics cannot.
Everyone reacts differently to it, so if you give just a little too much, that can bother someone else.
Yeah, but that's the same with dopamine, atropine, morphine. I mean, you give them a drug that can make you quit breathing and paralyze you, but you can't give them insulin, right? You trust them with the lethal drugs that you know will kill people, but I mean, I'm a big fan of not giving them anything because I don't think they're trustworthy individuals, but that's just my personal opinion. Kidding, kind of. That's the glucometer. Those are strips, right? This is alcohol prep. These are lancets, or the pokey thingies that everyone calls them, pokey thingies. Okay, there's a million different types of these, and there's a million different types of these. And there's like 50 different kinds of these. What's that? Pokey thingy. Yeah, you can put that in your report. No, don't do that. Don't put that in your report. I'll kill you. What's that?
Is that one of our medical receptor terms?
Yeah, medical extension, a pokey thingy, yes. Let's take a quick break. Stand up, stretch.